This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2017, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Impact of a Respiratory Therapy Assess and Treat Protocol on Adult Cardiothoracic ICU Readmissions. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Mr. David Wheeler. Mr. Wheeler is a registered respiratory therapist, neonatal pediatric specialist, and fellow of the AARC. He is the coordinator of outcomes and quality for the Center of Telehealth at the Medical University of South Carolina in Charleston, South Carolina. Mr. Wheeler is an experienced researcher, presenter, and author. Mr. Wheeler has no relationships to disclose. I disclose that I am a paid employee of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. David, welcome to the program.
Well, thank you very much. I really appreciate the opportunity. I'd like to thank the AARC for inviting me to discuss this actually wonderful paper, and I'd like to thank everybody for participating. Just by doing so, you're showing that you're engaged in your profession and you have a commitment to your patients. So let us begin the examination of this great paper from the May Journal, The Impact of Respiratory Therapy Assess and Treat Protocol on Adult Cardiothoracic ICU Admissions. So in our first slide, I had to do a little recognition that today is the day that Anne Boleyn was beheaded in 1536. And obviously we're in a state in healthcare today where we don't want that to happen to us. And using the evidence, taking the best evidence and applying it to the bedside, being practitioners that are engaged in our profession, joining the ARC, participating in their programs, is one way to avoid such a fate. As a matter of fact, I think this paper points and highlights to the very strategies, the very techniques that we can use to actually strengthen our profession. So I have to talk about protocols to begin with. We're doing a paper or reviewing a paper about what a protocol is. And many people with significant experience, both as researchers, authors, and just people who were always engaged in finding the truth and the best evidence for our patients, have developed protocol service. And they're really patient-centered protocols. They're assessment-driven, evidence-based protocols where we have the opportunity to bring the best evidence to the bedside. The godfather of all protocol services is Jamie Stoller from the Cleveland Clinic, who really published significantly vetted protocol services that have been used around the world. Rick Ford, has also done significant work. Lucy Kester, Rob Chadburn. We could go on and on. But a protocol is a guideline that is an algorithm, and it helps us to provide our therapy, and it helps and empowers the bedside therapist to initiate, discontinue, define, transition therapy as patient's condition dictates. So it's real N of one medicine. We have demonstrated, and has been demonstrated, to improve patient outcomes, to help us to give the appropriate therapy to the appropriate patient in the appropriate time. It assures that treatments have the evidence-based indicators. And the main thing, and I know all of us are being overwhelmed at the bedside these days, it helps to reduce the volume of unnecessary care. This is a protocol from the Cleveland Clinic, and I just throw this up as an example. We have an assessment, and then based on that assessment, you can treat. Here's another protocol from Memorial Medical, very nicely done. Evidence-based, and guess who's providing the evidence? We are. We have the evidence from the literature, but also the evidence from the patient in the context of their bedside care. This is a really nice-looking protocol from Barlow, and obviously somebody there is graphically gifted. I wish I could do such a protocol. Here's one from the mind of Brent Kenny at Mercy Medical System, and really this is clearly articulated once you get using, and that's part of the beauty of protocols, is that you clearly articulate the best evidence at the bedside. Now to the paper at hand. It's a retrospective medical record review. And in a retrospective medical record review, we kind of look at what the practice has been, and we take and try to look at different phenomena that have been manifested in our patient population. And we try to either link or unlink phenomena, looking at why things happen at the bedside. So in this one, it's a report on recidivism to the ICU among adult postoperative cardiac and thoracic patients managed in a respiratory treat and assess protocol. This was really nicely done by Daly, Malinowski, Bacher, and Rowley, Professor Rowley at the University of Virginia. The primary null hypothesis is that there was no difference in all-cause unexpected readmissions and escalations to care between the respiratory protocol and physician-ordered group. The secondary null hypothesis is that there's no difference in primary respiratory-related readmissions to ICU length of stay or hospital length of stay. We must discuss, however briefly, the concept of a null hypothesis. A null hypothesis is a broad assertion that there's no relationship between two measured phenomena or groups. So if you refute a null hypothesis, you're concluding that the groups are linked, the phenomena are linked spatially and chronologically. Can be both, can be one, can be the other. It's symbolized as H with a lowercase 0, and we talk about it as H null, or hypothesis null, or hypothesis not, H not. The null in context, this is a null in the context of a typically accepted fact, and some people have talked about as a groupthink hypothesis. So, you know, what we do around here might be something that we would look at. So respiratory therapy, assess and treat protocols obviously have been shown to be effective in the alignment of care and interventions to the patient. They reduce the incidence of unnecessary care, ICU length of stay, and length of stay in the hospital. And this has been demonstrated in many, many thoughtful and well-done published peer-reviewed journals. So ICU readmissions and unexpected ICU admissions are linked to a longer critical care or hospital length of stay, greater in-hospital mortality, increased costs, obviously. And this is something interesting about this paper, is that I think, once we're through discussing, and I'll bring this point up again, that we will have the opportunity to use this kind of literature to go to administration and say, yes, we realize we're not making you money these days, but we are in the loss prevention business. And using an evidence-based, assessment-driven protocol can drive that. We can actually lose less money by using this, or we can spend less money per patient. So patients with severe and complex illnesses are more likely, obviously, to be readmitted. So using these kind of tools, and again, this is a tool. We can't replace the great therapists at the bedside, but we can give them some really good tools. And this is an excellent one. So they developed this respiratory treat and assess protocol. It's a therapeutic intervention guide for lung expansion therapy, guiding our care, bronchial hygiene, guarding and guiding our clinical armamentarium. They measured qualitative and quantitative outcomes, and in order to measure and thoughtfully look at the effectiveness, and applied the protocol to patient adults in the cardiothoracic postoperative care. It's a retrospective medical record review, again, looking at how phenomena are linked. It reports on bounce backs, meaning who comes back to the ICU. We treat them, we do a lot with them. Do they come back? Or bounce up? They've been on the floor, they've been doing reasonably well, and now we have to escalate the level of care. So adult postoperative cardiothoracic patients, and compare the results to the historical performance, hence the retrospective nature. Single center retrospective analysis at the University of Virginia between November 2015 and October 2016. Use registered respiratory therapists. Excellent. And it is a quality improvement project. And many times, for those of you out there wanting to do studies, if you encapsulate your study in a quality improvement shell, you can actually get an expedited review through your IRB. And that's critically important because we are improving care. We are looking at what we do and examining what we do with a very, very critical eye to improve our care to the patient, deliver great care to the patient. They looked at 1,400 records. Physician-ordered respiratory care group was a control group, and there were 730 in that group and 670 in the respiratory arm of the group. ICU readmission is defined as a return or escalation to the thoracic cardiovascular postoperative ICU. So they're defining this. You know, it sounds rather simple, but many times we have escalations in care that kind of fly under the radar. Oh, you know, the guy went to the unit and he was there for, you know, a day and then went back, and many times we just go, you know, it's just part of the process, part of the trajectory of critical illness. And there is a specific trajectory to being critically ill, and postoperative cardiothoracic patients are on part of that trajectory of their illness. So this examines if they bounce back or bounce up in that scope of care, in our scope of care. Primary outcome of this project was unexpected readmissions and escalations to the ICU. So the primary null hypothesis, again, there would be no difference in all-cause unexpected readmissions and escalations between the respiratory care group and the physician-ordered group. The secondary null hypothesis is there would be no difference in primary respiratory-related admissions. Now, a lot of us are out there. See, this is the difference between evidence and anecdote. A lot of us are out there going, well, I know, you know, how this is going to work out. I know how this paper is going to work out. But now we have the evidence. Now you can walk into your medical director's office. Now you can walk into an administration and say, you know, we need these resources. We need more resources because we can save you money. We can get people out of the hospital earlier, and we can get people out of ICU earlier. That's why this is a critically important paper and very well done by this excellent group at the University of Virginia. So the protocol is driven by standardized patient assessment tool. Assess the patient in real time and then apply the best therapy to that patient. It's based on evidence, based on how the patient presents. All of us, in the context of illness, present our illness in a very, very specific way to each person, to each bedside. Context is the immutable covariant. Remember this, my friends. Context really is the immutable covariant, and it will change. You can have people in a room, and for some reason, you know, they crash. We all have that room in our hospital, 309. Man, everybody codes in that room. Well, obviously, I'm not adhering to any kind of mojo of the room, but I'm saying, and again, specifying that the context is the immutable covariance. So individualized respiratory severity score, which is good, we'll look at it. It directs their clinical interventions. Again, our clinical armamentarium is directed by evidence, not by caveat. It's based on a very, very specific algorithm, which we'll look at, and it's integrated in the physician order entry in the electronic medical record. It's a three-phased approach. The orders for therapeutic interventions are based on severity scoring of the patient. How is that patient manifesting their disease state? And how that patient manifests that disease state will dictate our therapeutic interventions. Respiratory therapy orders were modified by the clinical assessor. Now, this is maybe the clinical assessors, if there were more of them or a number of them, some people would say, well, we have inter-rater reliability or variability. But I would assert that if you're doing a protocol service for any length of time, that over time your assessors and your raters come closer together in how they assess the patients. It's in the early phases of these implementations of protocol service that you iron out and look at and examine it thoroughly, looking at all the variables. And complexity, we have, in complexity science, you look at emergent phenomena. Well, some of the emergent phenomena that people have talked about is that over time, the raters get closer together, not farther apart. So it's a retrospective analysis. Subjects were bounced up or back, and again, we discussed this. So they analyzed the data continuously and looked at the different variables. Here is this wonderful, I can't say it enough, protocol. It's clearly articulated. That's the key about a protocol. You have to clearly articulate your idea, your notion of care at the bedside. And Daly, Malinowski, Bacher, and Professor Rowley have done just that. An exceptional job here. We'll look at each phase of it. So, physician order for therapy to evaluate and initiate care. Now, the indications for lung expansion are on the left, very, very reasonable and sound, based in evidence. If you're thinking about a protocol or looking for a protocol, you can do no better than to call these folks at the University of Virginia. I'm sure they'd love to hear from you. But it must be grounded in evidence. That's the key. Evidence-based, assessment-driven care. We're bringing the world's best evidence to the bedside of the patient. We have a moral imperative. I'll repeat that. We do have a moral imperative to assuage human suffering where we find it. And we have to do that with the evidence, not with how we feel, not with this is how we do it here, not with, oh, gee, last week this worked. No, we have to look at each patient. And it can be arduous work. It can take more time to sit there and assess a patient, but it is well worth it for them and for us. Again, we do have a moral charge, a moral imperative to assuage suffering where we find it, and using the evidence is the way to do that. On the right-hand side, conditions associated with risk. This is kind of the middle part of that protocol that we were looking at, and it's a scoring system. So if I have a clear chest x-ray and I don't have surgical neuromuscular status involvement, I get a 0 and a 0. And if I'm walking around, guess what? 0, 0, 0. How many times have you heard? And every department has that table where people sit around and complain about A, the manager, and B, what they have to do. It's called I call it the evil table in every department, but it's okay because we're evolving. We're evidence-based and assessment-driven. Emergent, inherently chaotic, complex systems, right? So they would say, you know, this guy was walking around the unit, reading the paper, and I had to give him a treatment. Well, what this would do is eliminate that unnecessary therapy. If you're in that category, using a protocol service, you can say, we'll make the therapy PRN as needed. However, if I have infiltrates, and atelectasis, a pleural effusion, you know, and I've had upper abdominal or thoracic surgery, then I score much higher on this protocol, and guess what? Elevates the level of care. So it's assess, and then based on the assessment, the scoring system, you are mild, moderate, or severe, and then we can look at the level of care to the patient. So a minimal score, you know, deep breathing, take deep breath, have a good time, you know, walk around the unit. Nothing can replace getting people up and moving, and we all know that. We've all experienced. But if they have a severity score that's very high, then we look at and assess and grant and give and perform therapy in an evidence-based way. What was interesting, when you look at Table 1, the subjects were reasonably matched. There's a little bit of a variance in severity, but I think, and I've seen in other papers, and this is very well done, that the bigger the group gets, these results hold true. what I'm interested in is the ICU length of stay. And if you look at the physician-ordered group, 3 days, 1 day less. I'll repeat that. 1 day less in the ICU on average for the respiratory treat and assess group, and 1 day less in the hospital. But look at the ranges, 2 to 6 for physicians in the ICU, 1 to 4 for the therapist-driven protocol for ICU length of stay. Hospital length of stay, 6 to 14, or 5 to 11. Now, if you're in the hospital for 2 weeks, it feels like a lifetime. It feels like another lifetime. And using this this protocol, any kind of assessment-driven, evidence-based therapy that a therapy tool that drives what we do, will critically impact the lives of our patients. Wow, I just had the right wow, because physician-ordered respiratory care in all cause ICU readmission, we are talking about a 9% versus a 6%. That is significant. Over a year, 5 years, 10 years in your ICU, you can make a huge, huge difference. A huge difference. We're talking in the lives of our patients. So this assess and treat protocol has a significant impact in the lives of your patients. I can pay no greater compliment to the authors of this paper than to saying they made a difference, a real significant difference in the lives of the patients that they serve, in the lives of the patients they come every day to take care of. They made a significant difference. I don't think any of us could pay them a greater compliment than that. And again, we see respiratory-related readmissions, physician-ordered group and the respiratory treat and assist group. Now, they were not able, with the power of the study, to refute the secondary null hypothesis, but we'll discuss that a bit later. And if you look at this table 4, the primary reason for respiratory-related readmissions, acute hypercapnic and acute hypoxemic failure, airway secretion retentions, in all categories, it is reasonably clear that the assess and treat protocol was successful and the way to go. It had an absolute risk reduction of 2.9%, 3%. So anytime that we can reduce our risk by any percent, we find that that is significant. So the respiratory-related cardiothoracic ICU readmission is lower in the treat and assess group. All-cause CT ICU readmission is lower in the respiratory protocol group. So the ICU recidivism is a significant impact. Unexpected ICU admission or readmissions, they had a significant impact. If you look at the blue highlighted area, the respiratory treat and assess protocol group had 1 day less in the ICU and in the hospital. So the study demonstrated clearly that we had a statistically significant reduction in all-cause ICU readmissions or unplanned admissions with the respiratory treat and assess protocol compared with physician-ordered respiratory care. However, not able to prevent non-respiratory related admissions. Did have some limitations to this study. It was a randomized assignment of subjects, unequal distribution of the case mix index. And that's something that I think if you could find something to comment about in this study, that would be it. However, when we look at the whole body of literature, where there's actually a well-developed canon of literature concerning the protocol service. And this question has been answered before in the work of Charlie Durbin and, again, Jamie Stoller, that this over time and over a number of cases does even out. The case mix index will demonstrate that a respiratory patient-centered, therapist-driven, and I like to call it that, a patient-centric, therapist-driven, evidence-based, assessment-driven protocol will out and will obviously prevail. So preference for respiratory care orders may have varied among physicians. However, when you're in a reasonably closed shop like University of Virginia, practice variation becomes less of an issue. Insufficiently powered, assessor was not blinded. Well, you can't blind intubation, you can't blind parachutes, and that's a problem with all device-related or critical care-related inquiry or investigation. It is terribly, terribly difficult to blind. So let's take a look at their conclusions. So they reject the null hypothesis that there is no difference in all-cause cardiothoracic readmission to the compared groups. So turning it around, we'll say, yes, there is a difference between all-cause readmissions. And the difference is that the respiratory therapy directed, the protocol directed, treat and assess patients had a better trajectory of illness. And this would be called, this whole thing is part of an aggregate of moderator variables. These are things that we do at the bedside that will have an impact, and little changes early on in the trajectory, especially if it has a potential for being a critical illness, will make big differences later on when we look through at this through the lens of complex systems science. We're adding a moderator variable, i.e. this protocol-directed care that has a significant impact. But they were unable to accept or reject a secondary null hypothesis that there is no difference in primary respiratory-related ICU admissions or stay. And again, I think if they probably, this group would do well for all of us. They could help us all by continuing this work and continuing to look at the outcomes, and let us know in another paper. I would welcome it, definitely. So protocol implementation demonstrated statistically significant reduction in all-cause ICU readmissions, and the reduction in respiratory-related ICU readmissions did not reach significance. Okay, but let's bottom line it for us, and let's talk about Robert Daly and Thomas Malinowski and Michael Bacher and Daniel Rowley, Professor Rowley. Well done, well done. Registered respiratory therapist, as a part of the interdisciplinary healthcare team, decreased respiratory-related adult cardiothoracic ICU readmissions when using this protocol. Again, I say well done. And I have to point out, Daniel Rowley has almost an alphabet behind his name there, and he happens to be a brilliant guy, and this is a brilliant group. Well done. People look at protocols and they act kind of like our little friend on the left there. It's always sit, stay, heal, never be innovative, think, be yourself. But I would argue, and I would assert just the opposite, that the protocol service enables us, empowers us to think and innovate. It gives us a tool to apply the best evidence at the bedside. And there's a lot of room to be innovative, especially in the care of the patients that we serve using the protocol service. And it does another thing that's interesting. So look at this pyramid for evidence-based medicine. If you look at the bottom of the pyramid, it's expert opinion. And you know what's below expert opinion? The notion, did you ever hear the expression, well, that's how we do it here. That's like 10 levels below expert opinion. This takes an evidence-based protocol, takes you up to the top of the pyramid. You're living in the world of systematic reviews, critically approved evidence-based guidelines, and critically appraised and looked at papers that have high power and that bring, again, the best evidence and to our armamentarium. We have this toolbox or this armory, and we bring it to the bedside of the patient and select, based on how they are presenting, based on where they are at in their trajectory of illness, based on their manifestation, their individualized, highly individualized manifestation of their disease state, we apply in a critical fashion the world's best evidence. So you're moving way up the pyramid, going from expert opinion, and even below that, that's how we do it here. I'm sure we've all heard that. And just another look at it, that, we're taking, when you take an evidence-based protocol, you elevate your practice, you elevate your profession, you elevate you at the bedside. Here's just another protocol. They are everywhere. This is for different device uses. This is one that we use in telemedicine for guidance. This is protocols really, to me, represent an N-of-1 clinical application. An N-of-1 is a construct of care. It's a construct of mind, actually, and it's the conscientious and explicit, judicious use of current best evidence applied to the decision-making process concerning the care of individual patients. And Guyot and company have provided us with a lot of work on N-of-1 clinical construct. But that's what we're doing. It's amazing. It really is compassionate care in its extreme. Remember I said before about the moral imperative to assuage human suffering? Well, the N-of-1 construct, driven by an evidence-based protocol, enables us to bring the best evidence in the world. Imagine that. No matter where the patient is, in our hospital or in our scope of practice or in our care, they're getting the best evidence at the bedside, individualized for their care, based on how they're manifesting that disease process at that moment in time. Because guess what happens? When you start doing protocols, you'll find that you'll go back and you'll assess again, assess and treat again. You'll go back on Tuesday and assess and treat again. Then Wednesday, assess and treat again. And their scores will change and your care will change. And guess what? The patient benefits from this and you benefit from this. For all the reasons we talked about, the N-of-1 model, the evidence-based, protocol-driven model, is really the archetype of patient-centric, evidence-based medicine. I'll repeat that. It's the archetype of patient-centric, evidence-based medicine. This is exciting stuff. It helps us to rewrite the patient care strategies in real time and remain attendant with any highly individualized patient context. People who write orders and expect them to remain relevant for even 10 minutes after they write them are clinically naive, I believe. This is really exciting stuff for all of us. And there was a dynamite editorial written by Professor Jones, Thomas Jones, he's at the University of Arkansas. And I'll just go over a few of the salient points. By the way, Dr. Jones happens to be a great medical writer. And it's the clinical application of a mature patient-centered protocol adds value to the organization. And it does solidify our position as an economic partner in optimizing the margin. So that's how you go to administration, and you can argue for positions. You know, definitely, you're saving a ton of money. You're getting people out of the ICU a day earlier. You get 10 patients out of the ICU a day earlier. That's $100,000 to $400,000 in cost savings or cost aversion for your hospital. You can definitely get positions with that. And I agree with his statement that the next decade can be marked with considerable progress in research, improvements in clinical practice, and breakthroughs for our profession. If every therapist, and that's you and me and you and you and you and me, will embrace the shared vision, we've got to take responsibility for our own corner of the profession and become a practitioner of influence who can articulate clearly who we are and the unique contribution we bring to the healthcare team. That is very, very important. We have to have a clear articulation of our place in the team and what we contribute. And our contributions are significant because we take care of the sick of the sick. And actually, I can use this to thank everybody listening because, in my mind, you've taken the extra step by just logging on today to demonstrate that you're committed to your profession, you're committed to the ARC, and more importantly, you're committed to yourself and your patients. You want to learn. You want to do the best for your patients. And being part of this process, this continuing education process, is a significant part of that. And so I'm honored by the fact that you're listening and you're participating. And I would just like to thank you again. Can't thank you enough. And you are the practitioner of influence. You are the one who can articulate who we are at the bedside, who and how we contribute in a very unique and authentic way. This is about finding professional authenticity. We're all talking about that. We're all looking for being genuine, for doing things at the bedside that bring value, that add to the safety, that add to the lives of our patients. Well, adding a protocol that is evidence-based and assessment-driven can add that professional authenticity, can add that unique slice of the pie that only we can bring to the patient bedside. The UVA protocol service is evidence-based, assessment-driven, really N-of-1 care. It's an extension of the best care to the patient, what they need, when they need it, and then reassess and treat in real time. Again, it's incredibly robust, and that's a continued individualized care and research. You're actually doing a research question on the patient with every patient encounter. It's robust and adaptive. Again, part of the inclusionary criteria for complex system science is this robust adaptability that is demonstrated through a protocol service. You can give the best evidence to the patient in the context of their disease state in real time. Imagine that. Yikes, who knew? Here's another protocol for PEEP titration at the bedside, and there's a lung that we used in the ex vivo state recruited. So protocol and evidence-based care and N-of-1. You talk about N-of-1. Have somebody's lungs on a table and treat them. That's N-of-1 care in extremis, you know. And Anne Boleyn, believe it or not, had her revenge. You know, she lost her head, but her daughter, Elizabeth I, the Golden Age, actually a fantastic ruler, some people say one of the best monarchs ever, and Shakespeare, Edmund Spencer, Christopher Marlowe, Walter Rodney, Bacon, John D. Drake, Hawkins, etc. So we are like Elizabeth I, and we are registered respiratory therapists, and we're part of the interdisciplinary team articulating a clear and unique vision of what we can bring at the bedside. We can decrease respiratory-related adult cardiothoracic ICU readmissions. We can treat our patients in real time using individualized, context-specific, archetypal delivery of care, and it can be protocol-driven. The protocols are alive. That's another point I'd like to make about it, is that they are adaptive. So as we get new evidence, we adapt them. And I would like to thank Robert Daly, Thomas Malinowski, Michael Bacher, and Daniel Rowley for their wonderful paper and wonderful contribution to the canon on evidence-based medicine. So with that, I will conclude, and we'll talk about upcoming events, I believe, is the next slide. Thank you. And we have time for questions, I am sure.
Hi, David. Thank you so much. That was fantastic. I really enjoyed listening to the presentation. We do have several questions, so I'd love to throw those at you. The first one is reflective of the beginning of your presentation when you were talking about the inter-rater reliability between the scorers. The question is about, are there any studies that define the difference between raters versus scorers?
Oh, that's an excellent question. And right now, I believe I ran into maybe one. And off the top of my head, I apologize, I don't have it in front of me. I think for most of the literature, the scorers and the assessors are kind of intermingled and considered the same person. And ideally, you would want every therapist in your scope of practice, every registered therapist should be empowered with a skill set to be a first line. You know, some people call them RT2s or RT3s. You know, they give them different designations. But ideally, you know, the majority of your department should be thoroughly trained assessors so that they can go out and not only perform the protocol service, but they should be able to score other people, especially new practitioners, people who are new to an assess and treat protocol should have probably multiple people assessing their assessments. So I don't know if that was clear, but in most of the literature, they kind of intermingle. Great question.
Thank you.
Any other questions? Yeah.
There are a lot of them, yes. One of the other questions is that one of the listeners has a protocol very similar to this, and they are experiencing a lot of questions about the X-ray itself. So specifically, how old is too old to use? If the X-ray was last week, yesterday, at what point would that artifact not work for the protocol?
That is an excellent, exceptional question. And in my humble opinion, and I think the literature kind of supports this, you want the X-ray as recent as possible. Once you've started treating the patient and you see clinically, a lot, the assess and treat protocols, you're really doing a clinical judgment of what therapy is appropriate. So I have a problem with an X-ray that's a week old, and we're going off of that because I could have had a pneumothorax, I could have had a collapsed lung an hour ago, and I could be fully recovered if I were a marathon runner, right? But all kidding aside, I would view and go heavily on clinical assessment, and if the X-ray were more than a week old, I would kind of take that out of the equation, and I would go more on mobility and clinical signs and symptoms. And if they need an X-ray, if they're sick enough to warrant an X-ray, then I would go with that. If they're doing so well that everyone says, no, they don't need an X-ray, then I would view that as reasonable evidence, given the context of the patient, again, and that trajectory of illness. I would view that as evidence that the X-ray is okay. If everyone agrees that they don't need one, they probably don't need one, and they're probably scoring to the better part of the protocol service. Does that make sense? I hope. So my basic answer would be, don't use it if it's more than a week old, or more, in some cases, more than a day old. You would go with a clinical assessment. It's a stronger argument for care. If they're up and walking around, you could get a week-old X-ray on somebody and, again, see several problems. But if they're up walking around and watching the Animal Planet when you come in and don't want to deal with you, the chances are they probably don't need to.
Thank you very much, David. The next question is from a participant who wonders, since most hospitals have intensivist and hospitalist physicians available 24 hours a day, and therapy change orders can be more easily obtained, would you consider assessment abilities more or less important than protocol-directed care?
Well, assessment abilities are the linchpin of protocol-directed care. All protocols that I've seen really are hinged on thorough patient assessment. And yes, you have intensivists and you have hospitalists, everybody's there, so make them your physician champions. The best way to get these things rolling is to make your physician partners understand that it's really their idea. That's what I always do, is get them involved early and get them involved often in the creation and editing. And remember, I discussed briefly that these are living documents. So assessment-based evidence, the evidence changes all the time. As long as you're grounded in the evidence, I really rely heavily on assessment. So you can't take that out of the equation. So they're always assessment-driven. And the assessment, the evidence informs the assessment is what I really mean to say. So you do the assessment, and based on that assessment, you click it into the protocol, and that will drive your decision-making. So I think they're appropriate everywhere. I think that, and there are studies out there that say they make the doctors better. Actually, when physicians train in a protocol hospital, when they go out on their own, they make better decisions. Jamie Stoller did a couple of papers on that are really actually wonderful and significant contributions to the literature on protocols. So I'm always a big fan of having a protocol and of involving your physicians and getting a physician champion that, again, nothing can replace putting your hands on the patient, listening to them, getting a thorough assessment, and then basing your care on that assessment in real time.
And David,
I
I
hope
think
that
that
answered the
takes
question.
us into, it does, and it springboards us nicely into the next question. What do you do when you have a physician who writes the order specifically for respiratory therapy, not to protocol the patient?
Well, there's a way to handle that, and it can get extreme. The first way I would do is I would sit down with them and have a meeting, usually with your educator or somebody. If somebody knows this physician and gets along with them, I would say, well, what is your problem with the protocol? What is your difficulty? And address those issues. You know, usually it's one or two things that they don't like, and so they disparage or put down the whole protocol based on one or two components that they might not agree with. And then you can negotiate. If, in fact, they just don't want anything to do with the protocol, then you can do what Professor Rowley and Bailey and colleagues have done and just start tracking data. And this is perfectly appropriate in the evidence-based world and in the current landscape in healthcare. We can drill down to physicians. So if your protocolized patients are getting out of the ICU 5 days earlier than his, then you go to your medical director and say, we have this one outlier, and next question will be, well, it's our medical director who says that. So if that's the case, that's another discussion. But with physicians who are outliers, nothing can bring them around faster than collecting data on their patients, and you're perfectly well within reason to do that, because we're here to take care of the patients, not to assuage people's egos. So if their ego is such that they want to go against the evidence, then we will collect evidence that shows that either they do better and then they can write orders for all the patients, or they do the same, in which case we'll continue, or they do worse, in which case they have to, out of just evidence, again, the moral imperative to do what is right for the patient, they would have to go along with the protocol. So start gathering numbers on their patients. You'll see how quickly it'll turn around.
And so the next question is, how do you keep your physicians updated on the current level of care your protocol is providing the patient?
Wow, that is a fantastic question. I found the most effective venue is an afternoon journal club with food. This may be, I don't know, it's a bribe, but it works. And under the guise of journal club, I would always, in another practice I was in, we would spend the last 5 minutes of the journal club. We would review salient papers in disciplines like mechanical ventilation. We would invite them to come and comment, and they would show up. And then we would spend the last 5 minutes talking about the data related to our protocol service. And in this forum, when you've already got them open up to discussing current evidence, you can get their contributions. You will find that as the protocol service evolves, you'll want to do things differently. And if you've got them engaged all the time, and you've got them looking at you as colleagues in evidence, colleagues in the science, colleagues who live in the literature, it's a lot easier to get their input on evolving a protocol. So this is really an important question, is how do you keep them involved? Well, you invite them in, and you send them, if they don't come, you send them an email with the data that you've collected on your protocols. You put it, the protocol service almost universally works, and almost universally does wonderful things for length of stay and for the trajectory of illness, as I've discussed. And when you do that, and when you can demonstrate that, it winds up in your whatever communication that the president or the CEO, you feed them this information. You feed the administrators. Definitely feed your medical director. And again, I didn't mean to create a pun here, but you create a journal club or some kind of collegial gathering. Invite them to review papers, and then share with them the numbers on your protocol service. And if it isn't going the way you want it to go, invite their input. People like physicians, you think about it. They've lived in the literature since they were in medical school, and they like being involved in creating protocol service. There's no quicker way to turn a physician around or get them involved and get them part of the living document than to invite them in and show them the data. Does that help? Or?
And I'm going to wrap up. It does. That was perfect.
Yeah.
I'm going to wrap up with one question about access. So this particular person has an interest in a list of the sources used to establish the research, such as respiratory care, JAMA, the NIH, nursing research, and so forth. The question is, most of the general public does not have access to this kind of quality research and review without being enrolled students with university library access. How do you suggest one overcomes access restriction?
That is a great question, and one of my favorite searches, I use Scopus. If you don't have access to that, then Google Scholar is tremendous for getting access. Most of the journals now will allow you to at least read their publications for free. I don't know if you can download them, but you can read at least the abstracts. If you don't have university access, many universities for free, if you join, I would just start clicking on medical university libraries. I think that certain libraries have like a minimal fee, like $10 a year, where you can get total access to their journals. Others do it for nothing. I don't have that at my fingertips, but I would just start investigating that. And the first place I would start is Google Scholar, and I would look for medical university library access. I would just throw in that, actually, as soon as we're done with this, I'm going to try it and look at that. Many things, I know people go a million ways with Google, but Google Scholar is a good place to start if you don't have access to like Scopus or PubMed. And I like Scopus because it encompasses everything, and I'm a pretty eclectic reader, so I found things in engineering that apply directly to the care of our patients that I've used. I hope that's helpful, and I'm one for open access. Whenever I hear a question like this, I pine for helping that person out, because I believe we all have really an interest, and we all should be able to access the world's best evidence. Again, we're talking about research that has been done on people who've been sick, and in a way, kind of a higher moral way, that information should be available to all of us.
David, thank you so much for joining us today. This was a phenomenal session.
Oh, thank you so much. I really appreciate being invited, and I appreciate all the wonderful questions everybody had. And I hope that we exceeded your expectations today as far as our session goes.
And thanks to everybody who joined us today. We invite you to join us.
Yes, thank you very much.
We invite you to join us for our next webcast on Tuesday, May 23rd, when Dr. Ben Francisco provides a session regarding assessment-guided asthma education. And then again on Tuesday, June 6th, with a presentation focused on the long-term oxygen therapy trial with Dr. Jerry Christian. The Respiratory Care JournalCast will return in August. We thank you for joining us, and have a great day.
Wonderful. And with that, I want to close out today's session with a huge thank you to AARC for putting this all together, and of course David for his excellent presentation today. In just a moment, you will notice that a Submit Credit button will appear on your screen. If you are an individual who has registered for this program, you will go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select Click Here button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This does conclude today's presentation. To end, simply exit out of your browser window, and we hope you all have a wonderful afternoon.